Usually when we think about like life-saving daily medications,
Yeah.
we picture these incredibly sterile laboratories.
Right, yeah, white coats, beakers, that whole pristine vibe.
Exactly. We expect our medicines to be born from, safety and perfectly controlled environments.
Yeah.
But what if I told you that one of the most widely prescribed foundational classes of cardiovascular drugs in modern history didn't start in a pristine lab?
It really didn't.
What if it started with a deadly toxin that triggers basically catastrophic internal collapse?
Yeah.
Okay, let's unpack this, because the origin story of the drug that you, or maybe your grandparents, take every single morning involves a highly venomous snake right in the middle of the Amazon.
It is honestly the ultimate medical paradox. I mean, we took the exact mechanism that a predator uses to kill its prey, and we sort of reverse engineered it to keep millions of human hearts beating.
It's wild. And whether you are a nursing student frantically cramming for your next pharmacology exam, or you're just an insanely curious learner trying to understand modern medicine, this deep dive is absolutely for you.
Yeah, today we're looking at ACE inhibitors.
Right. You probably know them as the pril drugs, like lisinopril, captopril, and elapril. They're universally known as, blood pressure pills.
Which is true, but also a huge understatement.
Totally. Our mission today is to look at the sources and uncover why that label is actually doing the drug a disservice. We're going to explore why this drug is truly a heart-remodeling powerhouse and how its most annoying, infamous side effects are directly linked to its superpowers.
Yeah, and to really grasp how these medications alter the architecture of the human body, we basically have to travel back to the Brazilian rainforest in the 1960s.
Okay, set the scene for us.
So researchers specifically, a Brazilian pharmacologist named Sergio Ferreira and a British pharmacologist named John Vane, were studying the venom of the Bothrops siraca.
And that's a deadly pit viper.
Exactly, a pit viper. And they noticed this very specific, immediate physiological effect in people who actually survived the snake bites. The venom caused a sudden, massive, and incredibly dangerous drop in blood pressure.
Like it essentially just bottomed out their cardiovascular system.
Right. And Ferreira isolated specific peptides from this venom. He called them bradykinin potentiating peptides, or BPPs.
BPPs.
Yeah, and he discovered that these peptides worked by blocking an enzyme in the human body that normally degrades a substance called bradykinin.
Right, so the venom stops the degradation, and then bradykinin just builds up. And since bradykinin is a massive vasodilator, meaning it, forces your blood vessels to open wide, the victim's blood pressure just completely plummets.
Which was a profound discovery all on its own. But the real scientific lightning bolt struck when researchers realized that this enzyme, the one that destroys bradykinin, actually has a second, completely different job in the human body.
Wait, really?
Yeah. Kinase II, which is the enzyme the snake venom was blocking, is actually the exact same molecule as angiotensin-converting enzyme, or ACE.
Oh, wow. So it's one enzyme doing two totally different jobs.
Exactly.
It destroys bradykinin, but it creates angiotensin II. And angiotensin II is a potent vasoconstrictor that spikes your blood pressure.
Right, so the snake venom was accidentally turning off the body's pressure-raising system while simultaneously cranking up the pressure-lowering system.
That's amazing. So the pharmaceutical industry sees this dual action mechanism, and I'm guessing immediately knows they need to put it in a pill.
They did, but turning venom into a pill proved immensely difficult. I mean, the first candidate was a compound called tepratide.
Okay. Did it work?
It worked beautifully to lower blood pressure in humans in the early 1970s, but there was a massive catch. It only worked if you gave it intravenously.
Ah, right. Because it was a peptide, if you tried to swallow it as a pill, your stomach acids and digestive enzymes would just chew it up and destroy it instantly.
Exactly. And a daily IV drip isn't exactly a practical solution for someone managing chronic high blood pressure at home.
And nobody wants to drag an IV pole around their living room forever.
Definitely not. So in the late 1970s, two chemists at the pharmaceutical company Squibb Miguel Ondetti and David Cushman took on the challenge of creating an oral version.
And they didn't just guess, right?
No, rather than blindly testing thousands of random chemicals to see what might block this ACE enzyme, they pioneered something revolutionary for the time, which was structure-based rational drug design.
Okay, here's where it gets really interesting for me. You can think of what Ondetti and Cushman did, like high-stakes lock-picking.
I like that analogy, yeah.
Back then, standard drug discovery was often like having a giant bucket of random keys and just jamming them into a lock one by one, hoping one eventually turns. But these two chemists took a totally different approach.
They studied the lock itself.
Exactly. They used a model of a related, well-understood enzyme carboxypeptidase A to map out the internal tumblers of the ACE active site. Once they knew the exact molecular shape of the lock, they custom-forged the precise molecular key to fit inside and jam the mechanism.
And that custom-forged key was a small, orally stable molecule that could actually survive the human digestive tract.
Which became captopril, right?
Yes, gaining FDA approval in 1981. It was an absolute triumph of rational drug design, happening years before the advanced computer modeling we rely on today even existed.
But captopril wasn't totally perfect, was it?
No, it wasn't without its flaws. It contained a specific chemical feature, a sulfhydryl group.
Which is basically just a sulfur-containing part of the molecule, right?
Right. And that sulfur group caused some pretty nasty side effects for some patients, specifically skin rashes and a condition called dysgeusia.
Dysgeusia. That's where you either develop a terrible metallic taste in your mouth or just lose your sense of taste entirely. That sounds awful.
It was. So chemists went back to the drawing board to refine that molecular key, and that effort led to the second-generation ACE inhibitors.
By getting rid of the sulfur group.
Exactly.
Yeah.
By removing the sulfhydryl group, they developed drugs like enalapril in 1985, followed by lisinopril and ramipril. They completely eliminated the metallic taste and the rashes.
And as a bonus, these new versions had much longer half-lives. So instead of taking captopril like 3 times a day, a patient could take lisinopril just once or twice a day.
Much better for patient compliance, yeah. And the generic names all end in pril, which is why they are affectionately called the prils in clinical practice today.
Okay, so now that we understand how they built the perfect molecular key to block this ACE enzyme, we need to look at what this enzyme is actually doing to our blood pressure in the first place.
We have to decode the RAIS cascade.
Right, the renin-angiotensin-aldosterone system. This is essentially the body's master control panel for long-term blood pressure and fluid regulation.
Let's walk through this highly calibrated system step by step because it's crucial.
Let's do it.
Step 1, your kidneys constantly monitor your blood pressure and blood volume. If your pressure drops or if the sodium delivery to the kidneys falls, specialized cells in the kidneys release an enzyme called renin.
Okay, so renin is step 1. Then step 2, that renin enters the bloodstream and acts like a pair of biological scissors.
Right, it finds a protein produced by your liver called angiotensinogen, and it snips a piece off,
Creating angiotensin of first, but at this stage, angiotensin I is completely inactive. It just circulates, waiting for instructions.
which brings us to step 3, the crucial moment. As that inactive angiotensin I flows through your blood, it reaches the lungs.
And the blood vessels in your lungs are heavily coated with ACE, angiotensin-converting enzyme.
Exactly. ACE grabs that inactive angiotensin I and converts it into the highly active hormone angiotensin II.
And angiotensin II is an absolute quadruple threat.
It really is.
First, it immediately constricts your blood vessels, spiking your blood pressure right now. Second, it signals your adrenal glands to release aldosterone.
Which forces your kidneys to hold on to sodium and water, increasing your total blood volume and raising the pressure even more.
Right. Third, it stimulates your brain to make you aggressively thirsty.
And fourth, and this is honestly the most critical point for long-term health, angiotensin II promotes pathological growth and scarring of the heart muscle and blood vessel walls over time.
We call this hypertrophy and fibrosis.
Yeah. So when a patient takes an ACE inhibitor, we block step 3. We stop the production of angiotensin II.
The vessels relax, so pressure drops. The kidneys stop retaining all that extra sodium and water.
Although it is vital to note here, because aldosterone levels drop, your body ends up holding on to potassium instead of excreting it in the urine.
Right, that is why hyperkalemia, dangerously high potassium, is a major monitoring concern for anyone taking a pril drug.
Absolutely. But what's fascinating here is how beautifully this illustrates the one enzyme, two jobs concept we saw with the snake venom.
How so?
By inhibiting ACE, the drug stops the dangerous angiotensin II. But because ACE is the exact same molecule as kinase T-thinate, the drug simultaneously prevents the destruction of bradykinin.
So bradykinin builds up, causing extra vasodilation, which pushes the blood pressure down even further.
Exactly.
Okay, let me push back on this whole concept for a second, though.
Sure, go ahead.
Angiotensin II is a highly conserved, natural evolutionary mechanism. It's a system designed to keep our blood pressure up and keep us alive if we get, say, severely dehydrated. or suffer trauma and start bleeding.
That's true.
So aren't we just disabling our body's own critical emergency survival system?
It's a great question. Evolutionarily, yes, the RAAS cascade kept our ancient ancestors alive when they were running from predators or surviving droughts.
Right.
But modern humans live much longer, and we deal with chronic conditions like hypertension, diabetes, and obesity. Those chronic conditions leave the survival system permanently switched on.
Aye.
When angiotensin II is chronically elevated for years, that emergency response becomes toxic. Think of it like a fire alarm that just never turns off.
It literally remodels the heart, making it stiff, scarred, and weak.
Exactly. We aren't disabling a necessary survival system. We are turning off a false alarm that is slowly destroying the house.
That makes total sense.
Yeah.
But dealing with the angiotensin side comes with a highly specific, very famous catch on the bradykinin side.
Yes, it does.
Because when you block an enzyme with two jobs, you can't control just one of them.
You're talking about the infamous pril cough?
Yes, the cough. Let's clear up a massive misconception about this. When bradykinin accumulates, it doesn't just lower blood pressure. It severely irritates the sensory nerve fibers in the airway.
Which causes a dry, persistent, tickling, non-productive cough.
And it affects roughly 5 to 20% of patients, with higher rates generally reported in women and people of Asian descent, likely due to, genetic differences in how bradykinin is metabolized.
Right, but the big misconception is that this cough is an allergy.
Yes, it is absolutely not an allergic reaction.
And that distinction is crucial for clinical practice. Because it's not an allergy, it is a mechanism-based class effect.
So if a patient develops this maddening cough on lisinopril, switching them to enalapril or ramipril will not solve the problem.
Not at all. The entire class of ACE inhibitors has to be abandoned because they all do the exact same thing to bradykinin. You have to switch the patient to a completely different class of drugs, like an ARB.
But the bradykinin buildup can trigger something far more serious than a cough, too. Angioedema.
Yes. This is rapid, localized tissue swelling, often in the face, lips, tongue, or airway.
And there's a dangerous misconception here, too. Patients often think, well, I've been taking lisinopril for 5 years without any problem, so I'm safe.
That's a huge mistake. The risk is highest in the first few weeks of starting the medication, sure, but angioedema can emerge at literally any point during therapy.
Wow, anytime.
Yeah, a patient could take the drug uneventfully for a decade and suddenly wake up with life-threatening airway swelling. Any new facial or tongue swelling on an ACE inhibitor is an immediate, drop-everything medical emergency.
That's terrifying.
It is. We also have to acknowledge a well-documented disparity here. Black patients have a 2 to 4-fold higher risk of developing this angioedema compared to other populations.
It's wild to visualize how this works. Think of the heart and vessels as a town threatened by a catastrophic downstream flood. That's the damage caused by angiotensin II.
Okay, I'm with you.
Taking an ACE inhibitor is like building a massive dam to stop that flood. It saves the town, but the water has to go somewhere.
Right, it backs up.
Exactly. It backs up and overthrows the reservoir, flooding a nearby neighborhood. That overflowing reservoir is the bradykinin causing the cough or the angioedema. The bug and a piece of the feature are mechanistically inseparable.
It's the biological price of admission for altering such a fundamental pathway. Yet these drugs remain among the most widely prescribed in the world.
Why is that?
Because they fundamentally change the trajectory of human organs.
To understand why this drug class represents a massive paradigm shift in modern medicine, we basically have to look at how medical thinking evolved, starting in the late 1980s.
Right, because at that time, doctors viewed heart failure as a one-way street. The heart got weaker, you gave patients diuretics to pee out excess fluid to manage their symptoms, and eventually the heart just gave out.
Then came the consensus trial in 1987. Researchers took patients with NYHA class 4 heart failure, meaning these patients had severe, exhausting symptoms, even while just sitting still in a chair.
The worst of the worst cases.
Exactly. They added enalapril to their standard therapy, and the results showed a shocking 40% reduction in 6-month mortality.
If we connect this to the bigger picture, we really have to ask why mortality dropped so drastically. It wasn't just because their blood pressure was a little lower.
It goes deeper than that.
It comes back to angiotensin II acting as a toxic cellular construction foreman. When the heart is failing, chronic angiotensin II tells cells called fibroblasts to lay down dense collagen.
It replaces flexible, healthy heart tissue with rigid scar tissue.
Yes. And olaparil essentially fired that formin. It stopped the collagen deposition, allowing the heart to maintain its flexibility and compliance.
Suddenly, heart failure became a disease you could actively treat and slow down at the cellular level.
Exactly. And once researchers realized they could rescue patients in the final stages of heart failure, a new question naturally emerged.
Could we use this exact same mechanism earlier to stop the damage from happening in the first place?
Right. And that led to the SAVU trial in 1992. They gave captopril to patients who had just survived a heart attack and had suffered damage to their left ventricle.
Because when part of the heart muscle dies during a heart attack, the rest of the ventricle tries to compensate by stretching out, right? Like a rubber band stretched too many times until it gets flabby and loses its snap.
We call this ventricular dilation.
So what did captopril do?
Captopril halted that structural ballooning. By blocking angiotensin II early, they prevented the heart from pathologically stretching and dilating over time. It stopped the structural remodeling before it could destroy the organ's pumping efficiency.
That is incredible, and that success pushed the boundary even further. If it works for severe heart failure, and it works immediately after a heart attack, what if a patient hasn't had a heart attack at all, but they are just at high risk?
Which brings us to the HOPE trial in the year 2000.
They gave ramipril to high-risk patients, people with vascular disease or diabetes, who did not have heart failure, and who do not even have particularly high blood pressure.
Yet the drug significantly reduced heart attacks, strokes, and cardiovascular death.
The HOPE trial basically proved that blocking angiotensin II cools off vascular inflammation, didn't it?
Yes. Angiotensin II creates oxidative stress inside the endothelial lining of your blood vessels, making plaques unstable and prone to rupturing. Ramipril stabilized those vessels.
Wow.
These three major trials forced a total redefinition of the drug class. ACE inhibitors were no longer just blood pressure pills. They became cardiac and renal remodeling inhibitors that provide massive organ protection entirely independent of the blood pressure numbers.
So what does this all mean? If blocking this RAAS pathway is so miraculous, and it saves lives by protecting the heart and cooling off vascular inflammation, why don't we just hit the pathway harder?
What do you mean?
Like, why don't we use multiple drugs to block the cascade in 2 or 3 different places at once to get double the protection?
It sounds incredibly logical. I mean, the medical community thought more is better, too.
Yeah.
But when they rigorously tested that hypothesis, it failed spectacularly.
Really? How so?
Well, in 2008, the On-Target trial tested an ACE inhibitor, ramipril, alongside an ARB, telmisartan.
An ARB is an angiotensin receptor blocker, right? It works one step further down the chain.
Exactly. Instead of stopping the production of angiotensin II, it just blocks it from binding to its receptor. The theory was, block the production and block the receptors for maximum defense.
Sounds foolproof.
But the reality was double the harm. The combination produced zero added cardiovascular benefit, but significantly increased adverse events.
Oh, wow.
Yeah, patients suffered severe hypotension, kidney impairment, and dangerous hyperkalemia. It became the definitive textbook example of why more drugs blocking the exact same pathway isn't automatically better. You cannot routinely combine ACE inhibitors and ARBs.
And the cardiology world faced another massive shakeup in 2014, didn't they? With the Paradigm HF trial.
Yes, they did. For 30 years, ACE inhibitors sat on the throne as the untouchable holy grail first-line treatment for heart failure.
But this trial tested them against a newer class of drugs called ARNIs, right?
You're right.
Angiotensin receptor neprilysin inhibitors, specifically a combination of sacubitril and valsartan.
And the RNIs reduced mortality so much more effectively that the trial was actually stopped early. Today, RNIs have largely dethroned ACE inhibitors in standard heart failure guidelines.
But that transition isn't just a simple swap, is it?
No, and this raises an important question regarding clinical safety, particularly for nurses managing these medication transitions.
Right.
ARNIs don't just block angiotensin receptors, they also inhibit an enzyme called neprilysin. And inhibiting neprilysin also increases bradykinin.
Uh-oh. So if you combine an ARNI with an ACE inhibitor,
You get a massive overlapping surge of bradykinin leading to an extreme risk of life-threatening angioedema. You can never combine them.
so what's the protocol?
Clinical guidelines enforce a strict 36-hour washout period when switching a patient from an ACE inhibitor to an ARNI to let the first drug completely clear the system.
We also have to talk about a massive trap regarding the kidneys. Throughout this deep dive, we've discussed how ACE inhibitors are renoprotective.
Yes, they protect the kidneys, especially in diabetic kidney disease, by lowering the pressure inside the tiny filtering units.
But in one specific condition, that exact protective mechanism becomes destructive.
The condition is bilateral renal artery stenosis, meaning the main arteries feeding blood to both kidneys are severely narrowed or clogged.
And the kidneys need a certain amount of pressure inside their filters to push waste out into the urine, right?
Right. In patients with this condition, angiotensin II acts as a clamp on the exit pipe of the kidney filter, keeping the internal pressure high enough to actually clean the blood despite the really poor inflow.
So if you give an ACE inhibitor to a patient with bilateral renal artery stenosis, you take away that crucial exit clamp.
Exactly. The internal pressure drops to zero, filtration completely stops, and you instantly throw the patient into acute kidney failure.
The mechanism that protects 99% of kidneys will shut down the kidneys in this specific patient. That is wild.
And a similarly devastating biological effect occurs during pregnancy. ACE inhibitors are a well-documented teratogen and are absolutely contraindicated in the second and third trimesters.
Why is that?
A developing fetus literally requires its own angiotensin II for normal kidney development. If a pregnant patient takes an ACE inhibitor, it blocks that fetal development, causing fetal renal failure.
Oh, man.
This leads to dangerously low amniotic fluid, a condition called oligohydramnios, which subsequently causes severe skull and lung malformations in the baby.
It's tragic. A drug that saves an adult's organs can prevent a child's organs from ever forming. We have covered an enormous amount of ground today, traversing from the venomous predators of the Amazon basin to the cellular mechanisms of massive clinical trials. Let's rapidly synthesize the 5 exam-style takeaways from our sources for everyone listening.
Number 1. Same enzyme, 2 jobs. ACE creates the damaging angiotensin II, but it also destroys bradykinin. That dual action is exactly why one single drug provides both the therapeutic benefits and the classic side effects.
Number 2. The cough is bradykinin, not allergy. It's a mechanism-based class effect. You can't just switch a coughing patient to a different pril. You have to change the entire class of medication.
Number 3. Protective beyond pressure. As proven by the Consensus, SAVE, and HOPE trials, these drugs prevent cellular remodeling, stop fibrosis, and reduce mortality in ways that are totally independent of simply lowering the blood pressure numbers.
Number 4. Watch the kidneys, watch the potassium, and watch for pregnancy. They can cause hyperkalemia. They will cause acute renal failure in patients with bilateral renal artery stenosis, and they are strictly teratogenic in the second and third trimesters.
And number 5. Angioedema is a lifelong unpredictable risk. It is not just a first-week side effect. Any new airway, lip, or tongue swelling in a patient taking a pril drug, even 10 years into therapy, is a drop-everything medical emergency.
As we wrap up this deep dive, I want to leave you with one final thought to mull over. We learned today that captopril, the blueprint for an entire class of life-extending cardiovascular drugs, was reverse-engineered from the venom of a Brazilian pit viper using early structure-based design.
It really makes you wonder.
It does. If one of modern medicine's most foundational, organ-protecting miracles was hiding in the venom glands of a snake, just waiting for the right chemist to unlock its geometry, how many other miraculous, life-saving cures are currently slithering or crawling or growing deep in the rainforest right now, just waiting for us to decode their secrets before their habitats disappear forever?
It really forces us to acknowledge how much of our future medical survival might be deeply tied to the wild, untouched corners of the world.
The ultimate paradox. The venom evolved to cause catastrophic internal collapse, gave us the exact blueprint to keep millions of human hearts beating steadily year after year. Thanks for joining us on this deep dive. We'll catch you on the next one.